Hey guys, welcome to week 2 of the Congenital Heart Disease series for the pediatric residents at UNC, rotating through the PICU. We've completed week 1, which was a review of tetralogy of Fallot. We underwent a simulation scenario where we practiced taking care of an infant presenting with a TET spell. Now we move on to week 2. Week 2 is really a pretty dense amount of material. I'm not going to spoil it here. We'll get into some quiz slides here in just a moment, but there's a lot of information packed into a short amount of time. This is a topic that's really difficult to cover in less than 20 minutes. Feel free to watch this lecture multiple times, send me any questions or clarifications that you need, or ask me for any resources that I use when I'm looking at this material and sort of relearning it, revisiting it. If you're able to attend this lecture in person on Friday morning, I encourage you to do so. It's a fun, interactive lecture. We use Kahoot, which is like a quiz, game show type of app. You get to compete against your classmates, and it's a little bit more fun that way. We'll look at the same questions here in this audio lecture, but I think the interactive nature of it, when you can be there in person, is a little more fun. But that's really all. We'll jump into it. The next slide is going to be quiz question number 1. Hope you enjoy. All right, question number 1. The EKG below shows what type of rhythm? Normal sinus, premature ventricular contraction, sinus tachycardia, premature atrial contraction. The answer will be on the next slide, but I want you to just pay close attention to the P waves, QRS waveforms. I think noting any subtle abnormalities in those waveforms will help give this answer away. All right, I'm sure all of you guys got it right at home. If you notice the P waves in the previous EKG strip, there were at least 2 in that rhythm strip that looked quite abnormal compared to the other ones that were normal in appearance. And so the answer is premature atrial contractions. Just a little bit about PACs. These are very common in hospitalized patients. These arise from ectopic pacemaking foci within the wall of the atrium. As the EKG in the previous slide demonstrated, the giveaway is abnormal P wave morphology followed by a normal QRS, which separates it right from a PVC, which is going to have an abnormal QRS waveform. The clinical significance of these in healthy individuals like you or myself, these are rather normal and insignificant. We may feel them as a palpitation or a flutter in our chest, but otherwise they're really without significant consequence. Who it does impact, though, are those with sick hearts, if you will, those that predisposed, particularly after cardiac surgery or chronic heart failure. Those types of patients, frequent PACs may predispose them to fall into a rhythm that can be very hemodynamically significant and even life-threatening. Things like AFib, A-flutter, AV-NRT or AVRT. The causes of these: think first electrolyte abnormalities, particularly low K, low magnesium. Otherwise, it's often related to pharmacologics and drugs such as caffeine, beta agonists, sympathomimetics. The answer in terms of treating these is addressing the underlying cause, and again, that goes back to checking electrolytes and replacing those, or if you're on a medication such as albuterol, for example, just being cognizant of the impact that may be having on your patients who are demonstrating PACs. Question number 2. The EKG below shows what type of rhythm? Non-sustained V-tach, ventricular quadrigeminy, ventricular trigeminy, or atrial trigeminy. I'll pause just to let you think about this one. What I want you to notice are the very abnormal QRS waveforms that you see on 2 occasions in this rhythm strip. Count the normal waveforms in between those 2 abnormals, and that will give you the answer. So you'll notice the abnormal QRS morphology in at least two of the beats in that prior EKG. This indicates a form of premature ventricular contraction, or PVC. If you were to count the number of normal beats that lead up to the abnormal beat, you would have counted 3 normal QRS morphologies with an abnormal. And so that was an example of ventricular quadrigeminy. There are variations in this. You may see couplets, you may see bigeminy, trigeminy, quadrigeminy, quadrigeminy, or even more. And so the take home really is looking at the QRS and noting its abnormal appearance. The origin of these, similar to what we talked about with PACs, it arises from ectopic foci within the ventricle. This ectopic foci conducts in such a way that it bypasses the normal His-Purkinje system and directly depolarizes the ventricle. The clinical significance of this, once again, like with PACs, oftentimes these can be normal. People under stress, sleep deprived, overdosed on caffeine, like many of us as trainees are. Those types of individuals, previously healthy, may experience these, and they are really of no clinical significance or concern. Once again, it's the patient that's predisposed, perhaps the patient who's post-op from cardiac surgery and suffering from low cardiac output syndrome. That's very common in children who just undergone cardiac surgery, or the child with a sick ventricle, if you will, like in dilated cardiomyopathy. These are the patients that are really at a higher risk for the PVC turning into something of hemodynamic consequence and clinical significance. This may transform into more of a malignant arrhythmia, such as ventricular tachycardia, AVNRT, AVRT. For the patient with frequent PVCs and a prolonged QT, perhaps the patient has prolonged QT at baseline and now they're acutely ill or they've undergone cardiac surgery. This is a predisposing risk factor to torsades de pointes. But also be aware of the many drugs that we use in the ICU that can prolong QT as well. Very important to, if you're seeing frequent PVCs, you've obtained an EKG, you note prolonged QT. Very important for you to review the medications that they're on and speak with the pharmacist and take off them or any medications that you can, so that you can hopefully avoid this complication. As we talked about with PACs, the treatment is treat the underlying etiology, replace K, replace magnesium, try to limit any offending medications or drugs that are exacerbating this issue. Otherwise, once again, very common in the hospital setting, the otherwise healthy patient having intermittent PVCs, not a patient that is high risk to decompensate. Number 3, the EKG below shows what type of rhythm: A, sinus arrhythmia; B, second degree Mobitz Type I; C, second degree Mobitz Type II; or D, third degree block. This one you really have to remember what distinguishes these different types of heart block. We'll get into that in the next slide, but pay close attention to the P waves here. You see that the P waves preceding a QRS maintain the same PR interval, and then intermittently you have these non-conducting P waves that seem somewhat random and when they arise. So you were correct in identifying second degree type 2 as the answer to this question. The EKG showed a consistent PR interval with an intermittent, spontaneously dropped QRS complex. This is in contrast to second degree type 1, Mobitz Type I, where you have progressive lengthening of that PR interval with an eventual drop QRS. First degree is marked by that prolonged PR interval sinus bradycardia, but otherwise nothing of remark on the EKG. And then third degree is notable for complete dissociation of your P waves and QRSs, or your atrial and ventricular conduction systems. Recall that first degree and second degree type 1 are generally benign conditions that oftentimes don't warrant further treatment, but second degree type 2 and third degree can be life-threatening and generally are going to require admission to the hospital and eventual pacemaker placement. So if that's a question on your boards or a scenario that you experience in real life, that's the correct answer, to get your cardiologist or cardiac ICU on the line and have this patient admitted. Third degree, generally we see this in the cardiac ICU setting after heart surgery done, where the conduction system is disrupted in the process of the surgery. Classic case of that would be the AV septal defect repair, where that conduction system is disrupted in the process of the repair. But there are some rare medical conditions associated with third degree heart block, not in the setting of a cardiac surgery. Question number 4. What agent is indicated in managing the following rhythm? A. Amiodarone, B. Esmolol, C. Verapamil, D. Adenosine. And so this really is asking you two questions, right? It's asking you to identify the rhythm and then recall, using either retention or your PALS algorithm, what the management step would be to resolve or treat this rhythm. So you notice the very wide complex tachycardia, pathognomonic for ventricular fibrillation. This is certainly a very important dysrhythmia for us to identify, both as general pediatricians or ICU physicians as well. This is an important rhythm because it is a shockable rhythm. You'll want to get pads placed on this patient and use your AED to analyze the rhythm and then potentially deliver an unsynchronized shock to the patient. Following the algorithm that I've listed here, you'll see that you'll shock the patient using 2 to 4 joules per kilo, and then administer amiodarone or IV lidocaine at the discretion of whatever your hospital has on hand that is quick to get to, or at the discretion of your cardiologist who you're consulting by phone or in person. On to the final question, question number 5. Which of the following is not used to manage the rhythm below in children less than 1 year of age? A. Vagal maneuvers, B. Verapamil, C. Adenosine, D. Synchronized cardioversion. Again, as in the previous question, this is really 2 questions built into one. It's asking you first to identify the rhythm and then recall what you would use to treat that rhythm. And by process of elimination, I think you can come to the correct answer here and which agent not to use. Well done, guys. So you were able to identify the rhythm as supraventricular tachycardia, or SVT. This is a narrow QRS tachycardia without a preceding P wave. By process of elimination, you are probably able to come to the correct answer of verapamil, which we do not use in children less than 1 year of age, and we'll get to that in a moment. But first, let's look at the table and walk through the stepwise approach to managing SVT. In a patient with stable SVT, you can first attempt vagal maneuvers. For the infant, this would include application of an ice bag to the face or inducing the gag reflex using a tongue depressor. In the older child, you can follow commands. You can ask them to bear down or blow heavily through a straw as another way to induce a vagal maneuver. If this fails to break the rhythm, or the patient decompensates into unstable SVT, which would look like hemodynamic compromise, poor perfusion, hypotension, then you'll want to reach for one of the more invasive steps. Typically, the first of which would be administration of adenosine. The first dose would typically be 0.1 mg per kg. You may attempt it a second time if the first dose does not break the rhythm. That second dose would be twice the dose, so 0.2 mg per kg. If you are still in SVT despite administering adenosine, or you're in a situation where you don't have IV access or quick access to adenosine at your hospital, and then you want to reach for your AED and perform synchronized cardioversion, typically at a range of 1 to 2 joules per kilo. The reason we don't use verapamil, there are some historical studies from many years ago showing a very large proportion of children less than 1 year of age in SVT treated with verapamil decompensating into cardiovascular collapse or shock. Again, these are historical studies and probably warrant some speculation, but it's so entrenched in our culture to not use it. It will still show up on your boards. Indeed, when I was reviewing for my boards, some of the resources that I use, I remember seeing this highlighted in red, bold, and large font. Those board resources really made a point to not use verapamil in this patient population because of cardiovascular collapse. And so I just wanted to share that board pearl with you guys. Hopefully you can remember it and get that question right if you see it in the future. All right, that's all I have for this week. I hope you enjoyed this talk on arrhythmias. A lot of material in a very short amount of time. Hopefully you'll get to join us for our simulation scenario on Friday afternoon and further, cement this material and help you recall it when you see it in the future. One resource I just wanted to share with you guys before I sign off. I've really found learnpicu.com to be invaluable for me as a PICU fellow. Speaking to arrhythmia resources, if you go to learnpicu.com, look under the cardiovascular section and the tab that says arrhythmias, you'll find some charts that review short EKG strips for arrhythmias that we need to know about both as general pediatricians and ICU physicians. And then you'll see a table that reviews all the anti-arrhythmics. And this is a really, really nice, succinct table that goes through the class that each anti-arrhythmic belongs to, what rhythm it's used to treat, and then some of the adverse effects that these are associated with. And so a really great resource. So that's all I've got for you guys today. Feel free to reach out to me with any questions or clarifications on the material. But until next time, take care.